All right, welcome everyone. It's great to be with you today. My name is Sophie Frank, and I'm a health educator with Project First Line. Welcome to the June topic of the virtual Train the Trainer workshops designed for skilled nursing facility educators. These workshops are brought to you by Project First Line with the California Department of Public Health and the Health Services Advisory Group. A few housekeeping reminders for today's workshop. This session is being recorded. We will post a recording as well as the slides from today's presentation on the Train the Trainer workshop resource page. You will also receive a follow-up email with relevant links. If your name does not show up, please right-click to rename yourself. This is how we will keep track of attendance. We ask that you please stay muted if you are not speaking, but we do encourage you to type any questions or comments in the chat or unmute during the discussion. We'll monitor the chat throughout and we'll address questions during the discussion. CEU are available for this workshop. Please stay for the entire presentation to be eligible for CEU. We'll go over how to claim CEU at the end of the workshop. Next slide. All right, so this is a slide we present in all of our courses to make ourselves aware of implicit bias. Implicit bias describes how our unconscious attitudes or judgments can influence our thoughts, our decisions, or our actions. This includes involuntary and unintentional perceptions made without us even being aware, and occurs as our brains sort information and perceive data to understand our world. Our implicit biases can affect our decisions, which can contribute to societal disparities. In being self-aware about our own implicit biases, we can promote healthcare diversity and equality. You can learn more about your own implicit bias at Project Implicit at the website listed here. Preventing urinary tract infections or UTI is a second topic of 4 in our Train the Trainer workshop series. These workshops are for skilled nursing facility staff responsible for training frontline healthcare personnel. This may include facility or corporate infection preventionists, directors of staff development, or directors of nursing. In order to provide effective training on UTI prevention, trainers need to understand UTI prevention concepts, know how to assess and reassess their staff UTI training needs, and be familiar with the available UTI prevention training materials and tools. Today, our partners at HSAG will provide an overview on UTI prevention practices and walk you through an available UTI prevention bundle for implementing and enhancing your training programs in your facility, ultimately reducing healthcare-associated infections and readmission rates. And now I would like to introduce you to our speakers today. Jeff Granzith is an equality advisor and infection preventionist with HSAG, and Karen Bertorano is a quality improvement specialist with HSAG.
Hello, everyone, and thank you again for joining us today. Today's presentation will describe the risk of healthcare-associated UTIs and SNFs, share evidence-based clinical practices that are shown to prevent UTIs and catheter-associated UTIs, which you know are CAUTIs, provide strategies to reduce healthcare-associated UTIs and CAUTIs, discuss adherence monitoring and feedback, and last, we'll review the HSAG UTI Prevention Bundle and Change Package. Next slide. I'm going to present an overview of the urinary tract infections, and for most of you, keep in mind this will not be new, but just a bit of a refresher. Next slide. UTI is the most common of all healthcare-associated infections. It occurs when the bacterium invades the epithelium cells, typically introduced via the urethra. The mechanisms of development include the ability of the pathogen to produce infection, or how strong the pathogen is and the strength of the individual's defenses or immune system, right? So in other words, the more compromised the resident's immune system, the greater the chance they have of developing the UTI. For example, a resident who's been on steroids for a long time or recently received chemotherapy is going to put those residents at higher risk. The most common is the lower UTI, known as cystitis, and located within the bladder and or urethra. And then we have the upper UTI, which happens to be the most serious, and this is within the ureters, the renal pelvis, or kidney tissue, and we refer to this as pyelonephritis. And as you can see, the UTI is most common in women. 60% of all women will experience a UTI at some point in their life, whereas men will be at 10%. So much more predominant in the female. Next slide. So what are the causes of a urinary tract infection? Well, we have the gastrointestinal bacteria, which we know is the E. coli. And you'll see on the next slide that it is the most common pathogen for the UTIs. We have the perineal bacteria, which is a result from poor perineal care. And that's why it's so important to provide that proper care. And then finally, we have the hands of healthcare workers. When we look at the etiology of the UTIs with the urinary catheters, we're looking at the cause may come from the external surface of the catheter or inside the catheter itself, which is a key reason why we need to maintain a closed system. Next slide. So as mentioned previously, E. coli is the most common pathogen in causing a UTI at 24%, whereas Pseudomonas and Klebsiella are equal at 10%, with Enterococcus being the least common at 7%. Now, just as a side note, I want to remind you all that Candida is the common commensal colonizer, and for NHSM purposes, not reported as the UTI, as it is a yeast infection, which does not respond to antibiotics. However, clinically, it may still require treatment, and diflucan remains the drug of choice for treatment. I also want you to be aware that recently, especially out west, that there has been a rise in cases of the resistant Candida, which unfortunately comes with a high mortality rate. Next slide. UTIs and long-term care and why this discussion is so important. So as you can see, the current rate is approximately 1.5 per 10,000 resident days and accounts for 20 to 30% of all infections in long-term care, quite significant. 7 to 10% of the residents that experience the UTI will have a urinary catheter, which is why we need to get that indwelling catheter removed as soon as possible. Unfortunately, the UTI is the type of infection which is not identified until it has already progressed to bacteremia, whereas bacteriuria is easily identified by testing and is quite common, as we know, but remember, not an infection and should not be treated with antibiotics, and really is truly a source of overprescribing of the antibiotics. I will now turn the presentation over to Jeff.
Great, thank you, Karen, and thank you all for joining. I'm really excited to be here with you today. So we're going to kind of pivot and talk about kind of the different types of UTIs and how we define them from that surveillance perspective. So next slide, please. Okay, so for our surveillance, we're looking at the National Healthcare Safety Network here. So that's CDC's our surveillance tracking system. I know all of you have probably gotten very familiar with them over the past few years. As you began reporting the COVID vaccine data and the COVID pathway data. But really, HAI surveillance has been done at the acute care hospital level for 10 plus years through this system. So they've got great surveillance definitions. They've got a long-term care component in which you can sort of track these HAIs, your UTIs, through that system. So we've got three definitions that we've got. So we've got your SUTI or your symptomatic UTI, and this is in your non-catheterized patients. So we need a positive urine culture and then those signs or symptoms. And then we've got a CAUTI, which is in your residents who have that indwelling urinary catheter, plus they've got the positive urine culture and then signs or symptoms. And then finally, we've got the asymptomatic bacteremia UTI or the ABUTI. And this requires sort of that positive urine culture in addition to a positive blood culture, and then none of those qualifying signs or symptoms. So next slide, please. Okay, so just kind of taking a little bit closer look here at the definition straight from the latest protocol from NHSN. And you can see there's three different criteria for the SUTI. So criterion 1, and again, this is residents without that indwelling catheter. So we need signs and symptoms. So we've either got to have acute dysuria, acute pain, swelling, or tenderness of the testes, epididymis, or prostate. And then in addition, that positive urine culture. I think it's important to note with all of our definitions, positive urine culture must have 100,000 colony-forming units and be no more than 2 species. So if we have that mixed flora, it's not going to meet that definition for the infection. So then criterion 2, we've got to either have one of the following. So we've got to have a fever or leukocytosis. And then in addition to one of these 6 symptoms. So the 6 symptoms include costovertebral angle pain or tenderness, suprapubic tenderness, hematuria, incontinence, urinary urgency, or urinary frequency. So one of those, and then again, we need that positive urine culture as well. And then criterion 3, we basically need 2 of those 6 symptoms we just covered. So we don't have the fever or leukocytosis, but we need 2 of those symptoms. And then again, we need that positive urine culture alongside it. All right, next slide, please. Okay, so now again, here's the CAUTI. So this is in those patients that have the Foley catheter. And it was, it's either been in place, or if it was removed that day or the previous day, we can still meet criterion for, what we call a CAUTI. So now we need, 1 or more of these symptoms. So we've got fever, rigors, new onset hypotension, new onset confusion, along with leukocytosis, new or marked increase in suprapubic tenderness, new or marked increase in the costovertebral angle pain or tenderness, acute pain, swelling, or tenderness, again, of the testes, epididymis, or prostate, or, some pus or, purulent discharge around that catheter insertion site. And same here, positive urine culture, no more than 2, organisms, and then the 100,000 colony forming units. All right, next slide. Okay, and finally, the ABUTI. So this is, this can be both, either a resident with a catheter or without, none of those symptoms we've talked about, no fever, none of those symptoms, and then positive urine culture and a positive blood culture. And I think it's important to note that the, organism must match between the urine culture and the blood culture. So if we've got, E. coli in the urine and Pseudomonas in the blood, that's not going to qualify because we're looking at different organisms there. All right, next slide, please. Okay, perfect. So that brings us to our first polling question. So we're going to open up this poll for you guys, and we just want to hear from you. Do you perform UTI surveillance in your facility? So we're looking at, yes, hey, we're using this NHSN criteria you just covered. Yes, but we're using a little bit different criteria. Yes, but, I'm not exactly sure what that criteria is. And then no, but we're, interested. We would like to start tracking this. And then finally, no, and, we're just not interested in it. All right, so we'll go ahead. I see a lot of responses coming in, so we'll keep it open until they start slowing down. And as I'm seeing them come in, I'm seeing, quite a few of that different criteria. So if you're using a different criteria and want to chat it in, go ahead and enter it in the chat box there. And again, I'll keep this open a little bit longer. All right, so I see the responses are starting to slow down. Let's give it 5 or 10 more seconds. If you haven't responded, get it in. Okay, I think that's good. Melissa, do you want to close that poll? And I'm seeing a dead split here. So we're basically 39% using, hey, we use NHSN, 39% who are using different criteria. And I've seen, obviously a lot of McGears come in there. And then we've got 16% saying, they're not exactly sure what criteria they're using. And then 4% who say no, but, they'd like to start. So hopefully through this presentation, you'll be able to pick up some ideas and, hopefully that's something you can bring back to your facility after that. All right, Melissa, so let's move on to the next slide. All right, so just want to kind of talk through that terminology again as we kind of covered those definitions. So, bacteriuria, and that really just means the presence of bacteria in the urine. And, this can be, if we're symptomatic, as we've met those criteria that we just showed in the definition, the possible or, really a probable UTI. And then, when it's asymptomatic, it's likely the case of, hey, this is colonization and not an active infection. As we mentioned, it is going to occur with or without that indwelling urinary catheter, although that increases risk. And this last one, no benefit for antibiotic therapy. That is for that asymptomatic bacteriuria. And then we've got bacteremia. And so that's the presence of bacteria in the blood. And obviously to identify this is through that positive blood culture. And then a little bit more on the ABUTI, which we covered. Again, no signs or symptoms, but then we have to have both that positive urine culture, that positive blood culture, and again, with or without that urinary catheter. All right, next slide, please. Okay, so so this really, hey, to go into the bacteriuria a little bit and really focus on that asymptomatic bacteriuria, because bacteria can be present in the bladder and not cause that infection, and really it's quite common, especially in our long-term care residents. And we know research has shown, hey, it doesn't increase mortality, it doesn't require antibiotics. It is a huge source of overuse and misuse of antibiotics in the nursing home. And I'll say, those patients that do have those Foley catheters, each day that catheter is in place increases that risk of that colonization with the bacteria. So you can see 3 to 10% increase each day that catheter's in. So you've got a resident who's been there 30 days with a catheter the entire time. It is pretty much a guarantee that that resident is going to have a bacteria in their urine. And it's important why, hey, we don't want to test, because otherwise we'd be treating everyone and even overusing those antibiotics more. All right, so next slide, Melissa, and I think here I'm going to turn it back to Karen to take over talking about some, kind of observing those symptoms.
Thanks, Jeff. So yes, we are going to talk about now possible symptoms that you may observe in your resident that has the UTI. This can include pain or tenderness in the kidney area. They may massage that area in an effort to relieve the discomfort. You may see the facial grimaces or hear moaning, and if severe enough, they may cry out in pain. You also may see the resident being restless or experience shaking from chills. We want to make sure that when we take their temperature, we monitor that closely, because they most likely will have a fever. It may be greater than 100 degrees Fahrenheit or just several degrees above their own baseline. And then when checking vitals, also pay close attention to the blood pressure. If they become hypotensive with a systolic BP less than 90, or there is a significant change in their baseline, this may also be indicative of a UTI. Keep in mind, if the blood pressure becomes dangerously low, they may be moving towards a septic condition. Next slide. So other symptoms you may see include painful urination or dysuria, new urinary frequency, urgency, or incontinence, gross hematuria. In other words, you'll be able to see that blood in the urine. And remember, if that resident has a catheter, we want to make sure the staff is looking at the urine and the tubing for the color, not the accumulated urine in the collection bag. The resident may also have a change in mental status. Again, keeping in mind that altered mental status alone is not an indication to send a urine culture. And last, there may be a change in the intake or output. Next slide. Now, let's take a look at who is at risk and why. Next slide, Melissa. Those residents who are at high risk for developing a UTI in a long-term care include those who have challenges performing activities of daily living, those with mobility challenges, ones with chronic conditions, and those with cognitive deterioration are more at risk. Next slide. Other risk factors or comorbidities, chronic conditions include diabetes, heart disease, those residents with renal failure, those who have been on steroids for long periods of time, or those, as I mentioned earlier, who received chemo, will most likely be immunocompromised, placing them at a higher risk. And then you have your residents with dementia and Alzheimer's, as they may not be cognizant of when they need a toilet, be able to perform that proper perineal care rate or hand hygiene. And lastly, the population that has the history of the UTIs. Next slide. Some risk factors are age-related. This includes physical changes to the genitourinary tract, including the neurogenic bladder, which is, as you recall, the name given to a number of urinary conditions in people who lack bladder control due to spinal cord or nerve problems. This nerve damage can result in the diseases such as cause multiple sclerosis, like the MS, diabetes, Parkinson's. And lastly, residents are higher risk if they become incontinent as they age, having mobility issues, or poor intake, especially fluids. Next slide. So Jeff is going to be doing a deep dive into catheter-associated UTIs. So I'm just going to provide you with a quick overview of device-associated risk factors. And as we can see here, they are improper insertion of any catheter, which that definitely places the resident at high risk. It could be the straight intermittent catheter, or indwelling catheter. So if a catheter has to be used, of course, we want to avoid the indwelling catheter as much as possible because that will increase their risk at most. And last, improper maintenance, which would include like the poor perineal care or not maintaining the closed system. Next slide. So we are to our next polling question. Do you perform a risk assessment on new residents for risk factors that put them at a higher risk for developing a UTI? A is yes, B is no, C is not sure. All right, so I am seeing that 59% do perform a risk assessment, 31% no, and 11% are not sure. So this clearly presents some opportunity for you folks that aren't sure or that you're not doing an assessment, because we'll get to the tools that can be helpful for you. UTIs and beyond. Why is it so important to prevent the UTIs? Next slide. And here's the reason. Because the complications of a UTI can be extreme. We want to prevent them as much as possible. I mean, these include persistent or chronic UTIs, chronic urinary incontinence, kidney stone, pyelonephritis, prostatic abscess, renal failure, sepsis, hospitalization, and even death. So this right here within itself is a key reasons why we want to prevent those infections, because ultimately death can occur, right? Next slide. So sepsis that is caused by UTI is known as urosepsis. It is an infection of the urinary tract that leads to a systemic response to the infection. Approximately 25% of sepsis cases are caused by UTI, clearly a significant percentage, right? It is critical to identify UTIs early and begin treatment as soon as possible. So all residents with UTI should be monitored for early signs of sepsis, including the temperature greater than 100.4, increased heart rate, altered mental status, respirations more than 22, and a systolic BP of less than 100. Next slide. Now let's take a look at how to prevent UTIs. Next slide. Frequent and consistent hand hygiene for staff, residents, and family members, especially before and after toileting. Perform purposeful rounding with toileting. Change soil pads as often as possible to prevent prolonged exposure to the skin. Perineal care, morning, bedtime, and as needed. And as long as the resident is not on a fluid restriction, encourage those fluids. Make sure we keep that water pitcher within reach and avoid caffeine, because as we know, it can cause dehydration and also be a risk factor for UTI in itself. Next slide. So I'm extremely excited to share the HSAG UTI Prevention Toolkit. The first part of this toolkit, which is on the screen now, is a one-page screening tool to identify residents most at risk for developing a UTI. You can begin utilizing this tool with new admissions, maybe including it as a part of your admission packet, and then rolling the assessment out to more seasoned residents. So the staff will check all the boxes that are applicable, and as stated at the top of the tool, a reminder from staff, for the staff, that if a resident has 3 or more of the factors, assessment of a possible UTI is advised. So basically they take this form, go into the room, look at the record, together do that assessment. If there's an increased age with any of the conditions below. So say the woman has a prolapsed uterus and she is greater than 65. She's had a prior UTI and she's confused. So I'm going to go to the next step and assess for that UTI so that I can identify it early on, especially if it's a new admission coming from a hospital. Next slide. The next UTI prevention tool is the Risk and Action tool. This would be implemented on those identified as high risk to UTI. So as on the previous slides, the risks are listed the same with the action for each risk on the right. For example, if we look down and we see, okay, the risk is bowel and bladder incontinence, bowel or bladder incontinence. We want to consistently perform that hand hygiene with soap and water or alcohol-based sanitizer, practice standard precautions, assuming all blood and body fluids and environmental surfaces could be contaminated with germs. We want to provide regular toileting, check those incontinent pads frequently, avoid skin exposure to urine and feces, and proper perineal care. cleansing the females, as you're aware, from front to back, and the male's foreskin if present. Essentially, this tool provides a plan of care for each of the risk factors identified. Again, a one-page tool, simple, check the boxes, and practice the actions that are listed. Next slide. So this is the bundle or visual cue poster that can be hung in the resident's room, any resident, but especially those who are at high risk. It provides a reminder to staff, residents, and family members, of UTI prevention strategies with the hand hygiene, fluids, pericare, and toileting reminders. Nice little poster, just hang in the room, easy to read, easy to see. Next slide. The next part of the toolkit is the assessment. How do we identify a possible UTI? So if 3 or more of those risk factors I previously mentioned are present, assessing for the possible UTI would be next, as I said. So if any signs and symptoms listed are present, from here, the next step is to report as further testing is recommended, and that reminder is at the top of the page. So we look here, we have the acute painful urination with facial grimacing, gasps or groans, fever. They may have blood in the urine and or a change in mental status. Again, change in mental status alone may not be indicative of UTI. Also remember that conditions such as Alzheimer's or dementia or medications can mask some of the symptoms listed. This tool can be used as an SBAR and is helpful when calling the physician to provide that report for them. It's also nice to use when you're getting a report from shift to shift. So nice, easy one-page tool. Next slide. This is the compliance piece of the toolkit of the UTI. This is the UTI audit tool is the compliance part. What gets measured gets managed, right? So we cannot fix something unless we know what part is broke. The intent for this tool is to monitor observations and discuss with the staff immediately after, possibly like at a huddle meeting. So this is utilized by the drop-down boxes on each of the lines with yes or no. Once that gets entered, so we look at what we have here. Staff performed hand hygiene before and after toileting, yes or no. Did purposeful rounding, completed AMHS pericare. And then once we put those answers in there, if you look down at resident 1 at the bottom, you'll see total % adherence per patient. Then on the right, which you can't see on the slide, but it will also give you the % of the measure. Then it automatically compiles that for you. Then if you look on the bottom right-hand corner of this slide, it also provides a nice bar graph showing % of compliance. So once you identify those areas of opportunities, you can talk about them immediately and then hopefully close those gaps. Nice tool, easy to use, easy to understand. And as you'll see when we get to the action plan, getting staff to help you out with this and monitor will be a big step in preventing urinary tract infections. Next slide. And here we have the action plan. So the top part is demographics, where you would enter the nursing home name, CCN, date, goal. Percentage of healthcare associated infection UTIs will decrease by blank % by blank date. So I want to remind you, please make sure that when you're choosing these numbers, it's something attainable and not something that's unreachable. So say we want to decrease UTIs by 30%, maybe by the end of the year, or 20% within 90 days. Pick something realistic. So we'll look down at the action. Review and update policies and procedures to reflect current evidence-based practices. Well, we know we do this for CMS, but specifically with the infection prevention piece to it, specifically UTI. The responsible person, most likely it's the IP, DSD at the facility. Data completion, we also can enter the date here that we want to complete, so our goal date. And then, of course, the end goal would be 100% of the policies and procedures updated. The next action we have is to identify those UTI prevention champions for each area unit. So as I mentioned, with the audit tool, somebody is identified as a champion on the units can help you with those observations and help find those gaps and identify the opportunities. So responsible person, usually again, the IP is often the one who chooses the champion. The data completion, say like 14 days, we want to have our champions identified. Then we move on to the conducting education with the teach back for staff, including nurses and nursing assistants. And this will include listed the pathophys, the clinical signs, symptoms, risk factors, and prevention bundles. So I want to mention here also that you will get the link for the tools, and I see that Erin's putting them in the chat as well, that there are webinars, short little webinars that Jeff and I have made, so that will help you and you can use to provide this education, right? So 7 to 10 minutes, the CAUTI one's a little bit longer, but you don't have to reinvent the wheel, so to speak. You can take our tools and again, use those to provide the education. Responsible person, data completion, and we really want a goal of 100% of the staff being educated for the UTIs and the prevention bundles. The other next action would be use the UTI risk form to identify residents that are at high risk, followed by implementing the prevention bundle for UTIs, for the residents identified as high risk as well, and then use the UTI abundance compliance tool to assess adherence to prevention strategies. Most likely, this is going to be nursing staff as well as IP, and data completion really should be ongoing. So when we look at the nursing home rules and we see, look at the percentage of residents that were screened for risk of UTI, this is where I'm saying I suggest that or recommend you start with those residents that are just newly admitted to your facility, then you can roll it out. So these numbers can change. Then we look at the percentage of the residents that had implementation of the UTI bundle, followed by performing 10 audits per week. And again, this is all based on the size of your building as well. And then what you want is your compliance goal. Nice one-sheet action plan. This is also found useful at your quality meeting so that you can report and have something in hand with numbers and your tentative plan documenting. At the end of the presentation, I will show you a completed document so you can get a better idea of what it looks like. And now I will turn it back over to Jeff.
Excellent. Thanks, Karen. All right, so now we're going to kind of move on and we're going to talk about, indwelling urinary catheters or the Foley catheter. So next slide. All right, so, 7 to 10% of residents will have an indwelling urinary catheter. I know it's probably not as high as we're used to seeing in the acute care hospitals, but still, a large number of residents that have these devices in place. I think, it's important to note, it is a very big risk factor and it predisposes that resident to a UTI, or as we call it, a CAUTI. So it's the most common source of bacteriuria, which we know can lead to that bacteremia and progress to sepsis, and then urosepsis has that very high mortality rate. All right, next slide. All right, so this is from the CDC and HCPAC, the guidance they put out. You can see the data on here. This came out in 2009. So this is something we've been working on for 14 years, but really they gathered all of the best practices, all the evidence, and we're able to identify best practices, who should receive a catheter, what are alternatives to catheters, best practices around insertion, best practices around maintenance, other quality improvement strategies that really work to prevent these CAUTIs. So all this evidence has been out there. We've been using it. And, it's a lot of the work that's gone in here, we've actually put into our bundle. So I think it's just important to note the data is there. The focus has been there, yet, we still see, these catheter-associated urinary tract infections. So despite the evidence all being there, there's definitely still work to do. And it's really just operationalizing the bundle and putting it into practice. So next slide, please. And so another document. So this came out a few years later, 2014. So SHEA and IDSA, so a little bit more focused, in the hospital setting, but sort of same practices and same, best practices. So, how to do that surveillance and detect the CAUTIs, kind of follow up on strategies to prevent those CAUTIs. So I think it's really important to note, two great resources, especially I, recommend you guys take a look through the CDC and HCPAC one, because it does a great job of outlining those best practices. But, it just shows this is a huge patient safety issue that we've been working on, but there is still work to be done. All right, next slide, please. Okay, so we've got another polling question here. So, we want to hear from you guys. What do you think are appropriate indications for a urinary catheter? And this is a select all that apply. So what are the correct answers? What is a good reason that, a resident could or should have a Foley catheter? So we've got incontinent residents. We've got, residents that have, acute urinary retention or obstruction. Those residents that, lack some mobility and have some mobility issues. Those with neurogenic bladder, or neurogenic bladder, excuse me. And in those who have, perineal or sacral wounds that are, stage 3 or 4, and the resident's incontinent and they're trying to heal those wounds. And then finally, resident on hospice or comfort, palliative care for end of life. So select all that apply, and we'll keep this open. I see a lot of responses still coming in, so give it another 20, 30 seconds. Get your responses in, and then we'll kind of go through the answers. All right, so it looks like we've slowed down. So Melissa, do you want to end that poll and share those results? Okay, so it looks like you guys have done well. So, there are really kind of 2 incorrect answers we were looking that don't apply here. So, incontinent residents is not an indication, for a urinary catheter. And then residents, with mobility issues, again, not an indication. So the others, I mean, it did well, hitting the urinary retention, 92%, 79 on the urogenic bladder, 79, the healing of the pressure injuries, and a little lower on that last one. And I know that's kind of, maybe not always the case. I think it's something that just, it's an option, for that comfort at end of life. All right, so next slide, please. All right, so, and this is really just covering them. So, this is the document I shared, previously, like I said, it highlights in detail, say, what are appropriate indications for a urinary catheter? So, acute urinary retention or obstruction, and then prolonged immobilization due to unstable spine or pelvic fracture. So, not just for your resident who lacks some mobility, neurogenic bladder, again, the healing of those perineal sacral wounds in incontinent residents, and this is for those stage 3 or 4 wounds, hospice, comfort care, palliative care for end of life. And then I think this is something you guys probably see a lot of, chronic indwelling urinary catheter on admission. And I think this is where it's important that you guys have a policy for evaluating it and making sure that the necessity is there. And, as you check on that resident, during their stay, does it become unnecessary later on where you can remove that device? All right, next slide, please. Okay, so, to oversimplify things, hey, how do you prevent a CAUTI? And, 2 ways. Hey, we avoid inserting that indwelling urinary catheter unless that appropriate criteria is met. And, we remove that catheter, as soon as possible. So as soon as we're no longer meeting, that criteria, we get it out. If, the line was, or the device was never placed, or it's removed promptly, we can't have that CAUTI because we don't have that device in place. All right, next slide. Okay, so then going into those, best practices, those prevention practices for CAUTI a little bit further. So again, insert catheters only for appropriate indications, and then leave in place only as long as needed. And then ensuring that catheters are inserted and maintained by properly trained staff. So I think it's so important that all of your staff who are, inserting, maintaining, have been trained on best practices and are competent and have gone through sort of that competency training and check. Perform hand hygiene, using aseptic technique and sterile equipment for insertion, and then maintaining a closed drainage system and unobstructed urine flow. And this one, using, kind of the bladder scanners to assess for urinary retention to kind of reduce that unnecessary catheterization. And then just internally, implement improvement programs that can, achieve appropriate use of your catheters. All right, so next slide, we're going to go to one more polling question. So we want to know, do you have a policy or procedure to assess for indwelling urinary catheter daily? So is this something that you got a policy where you're assessing for that need on a daily basis? All right, Melissa, let's go ahead and end this poll and share those results. So we've got, hey, 55% of you guys have a policy or procedure to assess for that need on a daily basis. But we've got 27% that do not, and another 18 that are unsure. So that might be an opportunity to take back after here and kind of follow up and see, hey, is this something that we can add and start looking for this, daily need. All right, next slide. Okay, so kind of that bundle approach to CAUTI prevention. So that insertion bundle. So, obviously, first and foremost, verify the need prior to insertion. If they don't meet criteria, let's not place it. And then insert that urinary catheter using aseptic technique. So make sure that individual who is inserting the device has been trained and competency-based, and then maintaining that catheter based on those recommended guidance. So if they no longer meet criteria, hey, let's remove that. So for that maintenance bundle, so documenting daily assessment of the need for it, ensuring that tamper-evident seal is intact, and then securing that catheter to the patient so it doesn't move around, performing hand hygiene before patient contact, maintaining daily meal hygiene with soap and water, emptying that drainage bag using a clean container and being careful not to contaminate the sides of it as well, and then maintaining that unobstructed urine flow. All right, next slide. Okay, and then just some myths. So like I said, to kind of publish the best practices. What has evidence-based practices? So here's some practices that don't have any evidence that these are reducing or preventing those UTIs. So these complex drainage systems that, like some that had antimicrobials sort of instilled into it. Changing catheters or drainage bags routinely. We don't want to change those on a routine basis. Antimicrobial prophylaxis, periurethral cleaning with antiseptics, or irrigation of the bladder with antimicrobials. And again, we don't want to be screening or routinely culturing, if there's no signs and symptoms indicating an infection. All right, next slide. Okay, so this is our CAUTI audit tool, and we created this. We've had a similar tool that we've been using for years with our acute care hospitals. And so we created this for the nursing homes, similar to the tool Karen showed earlier. It's built in Excel, and it really focuses on, sort of that CAUTI bundle. So, we're focused, you can see there's kind of, each Foley catheter resident, you've got a drop down of yes, no responses. So you can do your rounding on them, and you've got direct observations, which include, is the system, the closed system maintained? Is the catheter secured to the resident? Is the tubing free of kinks and, unobstructed urine flow? Is the bag below the bladder? Is the bag not, sitting on the floor? So all those direct observations, and then we've also got a chart review, which, focused on, peri-care, both in the morning and in the evening. And then indication. So has that indication been assessed for that day? And so what's really cool is you can, kind of round on it and then bring back these results. And the first page where you entered the results on the Excel will actually translate to a couple different graphs here. That one, I think there's actually 3 graphs. So there's one where you'll get your direct observations. And again, you can see, hey, what's our adherence? Where are we doing good versus where do we need some support? And then another one for your chart review. And there's actually a third one that kind of just puts it all into one. So you can see and really share those results for, hey, how are we doing? And then see, after you've implemented something, do we see those bundle compliance numbers go up? All right, next slide, Melissa. Okay, so now let's move on to testing and treatment of UTIs. All right, so next slide. Okay, so these are just some common UTI myths that I will say they very well might be a kind of an indication to investigate further, and hey, they might be, but in and of themselves, these myths aren't a UTI. And so we hear people say, well, their urine was cloudy and smells bad, they've got a UTI. Well, again, so it doesn't necessarily mean it's a UTI. Saying urine has bacteria in it. Well, that could be that asymptomatic bacteriuria we talked about before. Urine's got white blood cells, or sort of the enzyme for the white blood cells, or the nitrates, which would indicate the bacteria. Bacteria in a catheterized urine sample. Oh, that's a UTI. No, not necessarily. And then that asymptomatic bacteriuria, will ultimately progress to a UTI. No, that's not true. We don't have any evidence that would say, that it is going to progress. And then again, falls in, acute altered mental status in and of itself does not, indicate that that's, a UTI for sure. All right, next slide. Okay, so I'm going to talk about kind of a urinalysis. So, we've identified a resident who's, got signs or symptoms. It's kind of our next step is order that urinalysis with that reflex to the urine culture. And then, obviously results that are going to indicate that, potentially UTI, the bacteria present, the pyuria or the white blood cells, or those nitrates present. All right, next slide. Okay, so this one, just kind of a urinalysis guide, and it kind of just looked at, this article looked at, test results. And so you can see here, so high sensitivity would be something where, hey, if we've got a positive test, it's likely a UTI. And then high specificity would be sort of a negative test. It's likely, not a UTI. But it was just interesting that, the white blood cells sort of had that high sensitivity, but a low specificity. And then we had things like the bacteria, the nitrates for the bacteria, and even the hematuria showing that high specificity. So obviously if they're not there, very likely or very good chance that obviously it's not a UTI. All right, next slide. Okay, so just turn into, urine culture don'ts. So, obviously do not perform routine urine cultures. So, the catheter has changed. It's not a reason to do a urine culture, or, you're getting a new admission from the hospital. After a resident has had a UTI, we don't want to, continually be testing for this cure. And then, independent altered mental status with no other signs and symptoms, not a reason to sort of order that urine culture. And then, we never want to draw the urine culture from that collection bag, right? We know that bag's going to sort of accumulate that biofilm. We're going to get that sort of contamination, and you're likely going to have that positive test. And then never store that urine sample at room temperature. So make sure your staff are trained that, hey, as soon as I collect that, that's got to be refrigerated or, immediately to the lab, for processing. All right, next slide. Okay, so tips for, collecting that sample, in a catheterized patient. So I think the most important thing is always follow your facility's policies and procedures. So, making sure your staff are educated, and then confirming that order and the resident identity, obviously performing hand hygiene, and then maintaining aseptic technique throughout the process. And I know when we're collecting too, we want to have that fresh urine. So we already talked, we're not going to draw from the bag, and hopefully that tubing wasn't already sort of kinked up where you've got urine in it, but you'd want to, hey, make sure it's all down, and then you can kind of clamp it or kink it up, and then you want to be checking that every, say 5 minutes, no longer, to make sure, hey, once we get that fresh urine in there, then we're going to scrub that hub, and then depending upon the system you use, collect it with that bag container, that syringe, to draw that sample out and then not contaminate the specimen cup, as you're transferring it. All right, then next slide. Okay, and then these are just, tips for that clean catch midstream urine sample. So same thing, making sure that the person collecting it here has been trained on your facility's policies and procedures. Confirm that order and resident identity. And I think it's important, don't just sort of give the resident the instructions and walk away, but that they've got to be, assisting that resident during this process. So hand hygiene, aseptic technique, and then making sure that we use those disinfectant wipes so, we don't catch some of that contamination. And then, using proper technique, and then, voiding some of that urine first and then catching it midstream, again, to decrease that contamination. All right, next slide, please. Okay, so some, treatment decisions for UTIs. So, I think we've talked about this already, but avoid culturing urine of asymptomatic persons. So, unless they've got those symptoms that indicate, hey, this is a possible UTI, let's not just be, culturing because we've got cloudy or foul-smelling urine. And then, and we shouldn't be testing them, but avoid antibiotics for asymptomatic bacteriuria. And then some of the symptoms we've, already touched on, but fever, that pain, hematuria, and then, urgency, frequency, or, painful urination in those non-catheterized patients. All right, next slide. Okay, so finally, just kind of our key takeaways from today. So, UTI in a nursing home, is very serious, but it is a preventable condition. And, we know if it's left untreated, UTI can progress, to Urosepsis, which has that very high mortality rate. So it's critical that we train and educate our staff to sort of recognize those signs and symptoms, so we can treat early. Indwelling urinary catheters obviously increase that risk of a UTI. So, if we can get them out, let's get them out. And then improper testing, again, where we've got that asymptomatic bacteriuria, huge source of overuse of antibiotics. So, like I said, we've kind of created these tools to utilize those prevention bundles and, help you guys prevent these UTIs.